have the privilege to start this session about the indication and stages of practice with NIV and iFlow, and I'm going to talk about the role of iFlow nasal oxygen therapy in hypoxemic respiratory failure. I have no conflict of interests relating to this presentation. So the goals of this presentation would be to review what we know about the physiological effects of iFlow in hypoxemic acute respiratory failure. What do the clinical studies say? And we're going to cover a few practical questions. Okay, so iFlow devices have been introduced in adult ICUs about 10 years ago. And initially it was presented as a new option for oxygen delivery with possible additional benefits. And within the last decade, it's been widely embraced by clinicians. As this study in France shows, it was a survey of practice that was done in 34 different ICUs in the northwest area of France. And they asked the physicians there if they were about their habits of use with iFlow, and 100% of the responders said they regularly used iFlow, and they actually used it as frequently as NIV. So the physiological effects of iFlow, like I said, when iFlow was introduced, there was it was suggested and proposed that it had many physiological benefits. Some of them because of the properties of iFlow, which were high FiO2s, iFlow in itself, and the fact that the gases were heated and humidified. So either those properties or the properties that these had on the patient's airways, such as increasing some level of positive airway pressure and decreasing the anatomical dead space. All these properties, it was suggested or speculated that you would have benefits such as improved oxygenation, improved respiratory mechanics, reduced work of breathing, or increased comfort. But initially it was not that clear, and there was a lot of discussion whether it was a real thing or just clever marketing. And there was also a lot of discussion about what phenomenon, what mechanism was bringing those benefits. So over the year, things became clearer thanks to physiological studies like this one that was made in acute hypoxemic respiratory failure patient, and eventually it was confirmed that iFlow indeed had interesting properties that were especially interesting in patients with an injured lung or with an injury-prone lung, since it was indeed increasing oxygenation and respiratory lung volumes, and it was decreasing the patient's inspiratory effort. So it is suggested that maybe it would also have a kind of a protective effect. So aside from its own benefits, we can say that iFlow also has also taken advantage of some of the bad press that NIV had received over those last couple of years about a potential deleterious effects on hypoxemic patients, as NIV is thought to maybe worsen the patient-induced, patient self-inflicted lung injury lesions. So iFlow is viewed as being maybe a safer alternative than NIV. Sorry. So now, do these physiological benefits translate into real observed clinical benefits for patients? So this study was published in 2015. It included patients with acute lung injury, and there were 3 groups: oxygen, iFlow, and an NIV group, which was actually an iFlow plus NIV group. And the authors have looked for intubation rates and mortality. And what this study showed was that on the whole population, there was a non-significant trend towards less intubations in the iFlow group. And they did a post-hoc analysis on the most severe group of patients who had a PF ratio of less than 200. And in this population, the decrease in the intubation rate was significant. This study also showed that the people in the iFlow group, the patients in the iFlow group had a better survival. So when this study was published, there was a lot of discussion and a lot of controversy, because strictly speaking, this study is negative on its principal outcome, which is intubation. So the authors discussed that probably this was a bit underpowered, since the global intubation rate in the control group was less than expected. So maybe not enough patients had been, maybe it was a problem of underpowered study. But still, the fact that the study showed a significant mortality decrease was hard to ignore, even though it was a secondary outcome. And also, a lot of the controversy was about what was suggested by the study, that NIV might be deleterious, since in the NIV group it was actually iFlow plus NIV. So lots of discussion, lots of controversy. So in that kind of situation, we like to be able to compare with other studies. The problem is that up to today, there is no other comparable study that was made in the unselected ICU population. What the other data that we have about iFlow, where there is a couple of RCTs that have been made in emergency room patients, but these are a different population of patients that are less severe. So all those studies have rather low intubation rates compared to the studies that would be made in the ICU. So they're underpowered anyway to show any difference in the intubation rates. There's been a study on immunocompromised patients that we're going to talk about, and most of the other studies were done either in the post-surgery acute respiratory failure, which is a different context than the de novo ARF that we see in the ICU. And anyway, some of the studies had sort of a mixed preventive curative strategy. And most of the RCTs were made in the prevention of post-extubation respiratory failure. Again, another context. So, sorry. So, excuse me. So another study was published in 2018, which was a study on immunocompromised patients. So it was quite a large study with over almost 800 patients. The inclusion criteria were a little bit less severe than in the Floralis study. And they had an iFlow group and an oxygen group. And this study was completely negative. There was no effect on mortality, no effect on intubation rates or other secondary outcomes. So there has been several meta-analyses that have been done. They don't exactly all have the same results because they didn't take all the same studies. This one was only took patients with hypoxemic respiratory failure, so no post-extubation and no post-surgery patients. And what it showed is that it didn't appear, thank you, to have an effect on mortality, but half of the patients on this evaluation come from the high study, the study about immunocompromised patients that was negative. But it does appear that iFlow decreases the risk of intubation with a number of patients to treat of 23. So to conclude on the clinical studies, the conclusion we can draw from the literature is that iFlow appears to reduce intubation rates in acute respiratory failure, and that probably this effect is more marked in the more severe patients. But I guess the main and the safest conclusion is to say that we're lacking of data in acute respiratory failure, and that most of the studies that we have were made in a completely different context. A few practical questions that clinicians often have is what level of flow or FiO2 should I use? It's been shown that many of the physiological effects are flow dependent, especially those that appear interesting in acute respiratory failure. In this paper, we see that the gain in end expiratory lung volume, the PF ratio, and the estimation of the patient's inspiratory effort were all increased by with increasing level of flow. So, so it is probably better to set the flow quite high at a level of at least 40 to up to 60 liters per minute, and the FiO2 should be targeted to for SpO2. There are still many things that we don't know. For example, is there a role or is there an optimal temperature, and what is the exact role of the size of the cannula, which has not been very studied. Also, we don't really know when and how should we wean the eye flow when the patient starts getting better. Another frequent question or concern is could eye flow cause patients to be intubated too late and therefore have a worse prognosis? This is a question that is a problem that has been demonstrated, for example, for NIV, so the same concern was here with eye flow. This is a paper from a Korean team, and they have led an observational study on patients that were intubated after having received eye flow, and they compared the patient who had an early failure and the patients who had a late failure, and they found that the people in the late failure group that were intubated after 48 hours of eye flow had a significantly worse mortality. So it's always difficult to conclude on that type of results because, of course, a late failure is also the sign of maybe a more severe or a non-resolving underlying process. But still, it is a concern. This leads to another question. Can eye flow failure be predicted? So in this recent paper, this team suggested to use the ROX index. The ROX index is the SpO2 FiO2 ratio over the respiratory rate of the patient, so it's pretty simple. And this team suggests that the two cutoffs for the ROX index at age 12, because they found that age 12 was sort of the cutoff of the patient who were intubated after the 12th hour at a worse prognosis. And so they proposed those two cutoffs that would allow to distinguish the patient who had a higher chance of success and the patient who had a high risk of failure. So this needs further validation. Before that, of course, it's the best advice is to use the good old clinical common sense. And of course, a patient with persistent or worsening signs of respiratory failure or a patient with hemodynamic instability should be intubated. So the main messages is that over the year, eye flow has been widely adopted by intensivists, and it's became a classic in our ICUs, despite having initially not a lot of evidence to back it up. And since then, the physiological benefits have been demonstrated. The clinical benefits in de novo hypoxemic ARF are less clearly demonstrated and clearly waiting for more data. And on the practical aspects, it's called eye flow, so the flow should be set rather high. You should, of course, monitor patients for eye flow failure and stay alert for more studies, whether it's on better patient selection, optimal settings, or how to best monitor the patient. Thank you very much.